Hello and welcome to my presentation. As you can see on the screen, our topic today is the lung diseases. This is the first lecture, and the subject can be looked at under the following headings like various inflammatory diseases including Sroupous pneumonia, bronchopneumonia, interstitial pneumonia, and other diseases. Let me begin the lecture by reminding you of the information about anatomy and histology of the lung and some issues on defense mechanism of the lung. So, the conducting structure of the lung include the trachea, which has horse-shaped cartilages, the bronchi, which have plates of cartilage in their walls. Both the trachea and bronchi have mucus-secreting glands in their wall, and the bronchioles, which do not have cartilage in their walls. The most distal is the terminal bronchiole. The gas-exchanging components comprise the unit distal to the terminal bronchiole, namely the acinus. Alveoli are lined by type 1 cells, which are large flat cells that cover most of the alveolar wall, and by type 2 cells, this is another type of cells, which secrete surfactant and are the progenitor cells of the alveolar epithelium. The alveolar capillaries exchange gas in the alveolar wall. Here you see the picture describing the microscopic structure of the alveolar wall. Note that the basement membrane, which is yellow here, is thin on one side and widened where it is continuous with the interstitial space, like here. Portions of the interstitial cells are shown. So you see here the capillary and capillary lumen. The inner layer of capillary is endothelium. Here you see the nucleus of the endothelial cell. Then we see basement membrane yellow. Here you see also the interstitial cells in the thicker area of the interstitium. And then alveolar space. Alveoli have the type 1 epithelium, which also covers the alveolar space, the inner layer, and also type 2, as I has already mentioned, which is involved in producing surfactant, which is needed to the working of the alveolar gas exchange mechanism. There are some defense mechanisms of the respiratory system, which you must remember. Because during the lung has developed effective defense mechanisms to cope with the numerous particulates and infections agents inhaled on inspiration. The nose and trachea warm and humidify the air entering the lung. The nose traps almost all particles more than 10 millimeters in diameter and about half of all particles with an aerodynamic diameter of 3 microns. Aerodynamic diameter refers to the way particles behave in air rather than to their actual size. You must remember that. The mucociliary blanket or cover of the airway epithelium disposes of particle between 2 and 10 micrometer in diameter. The ciliary bit drives the mucous blanket toward the trachea, and particles that land on it are thus removed from the lungs and swallowed or coughed up. So also within the defense mechanism, we must include alveolar macrophages, which protect the alveolar space. These cells are derived from the bone marrow, probably undergo a maturation division in the interstitium of the lung, and then enter the alveolar space. They are particularly effective in dealing with particles whose aerodynamic diameter is less than 2 micrometer. Very small particles are not phagocytosed and are inhaled. Here we see the picture describing one of these mechanisms. So you see deposition of particles in the respiratory tract, and you see that the large particles are trapped in the nose. These particles are more than 5 microns in diameter. Then we see the mechanism, defense mechanism for 3 5-micron particles. So intermediate sized particles deposit on the bronchi and bronchioles and are removed by the mucociliary blanket. And then the smallest, less than 2 micron, smaller particles terminate in the air spaces and are removed by macrophages. Very small particles behave as a gas and are breathed out. Here we see 2 examples of non-immune lung and example of immune lung defense mechanism. In the non-immune lung, removal of microbial organisms depends on entrampment on the mucous blanket, which is shown as green here. Look, this picture is green, as removal via the mucociliary elevator. The second, phagocytosis by alveolar macrophages that can kill and degrade organisms and then remove them from the air spaces by migrating onto the mucociliary elevator. Or the third possible mechanism, phagocytosis and killing by neutrophils recruited by macrophage factors. The fourth mechanism, serum complement may enter the alveoli and be activated by the alternate pathway to provide the opsonine C3b that enhances mechanisms of phagocytosis. Organisms, including those ingested by phagocytes, may reach the draining lymph nodes to initiate immune responses. So, what happens to the immune lung? The first one, when secreted immunoglobulin A, can block attachment to the microorganism of the macroorganism to epithelium in the upper respiratory tract. Then the second one, when in lower respiratory tract, serum antibodies like immunoglobulin M and G are present and working in the alveolar lining fluid. They activate the complement more efficiently by the classic way, yielding C3b. In addition, immunoglobulin is opsonic. And the third, The accumulation of immune T cells is important for controlling infections by viruses and other intracellular microorganisms. So you see here how the defense mechanism operates in lower respiratory tract with the involvement of immune cells and immunoglobulins, etc. Let's start talking about acute inflammation, diseases of the respiratory system, and you know that they're extremely common in our everyday life. The causes are quite various. The first are infections like bacterial infections, Streptococcus pneumonia, Haemophilus influenza, pneumococcus, Streptococcus pyogenes, Staphylococcus aureus, viruses like adenovirus, respiratory syncytial virus, measles. Also, we must remember about mycoplasma, fungi, chlamydia, rickettsia, and others. Physical factors like dust, steam, radiation, and toxic factors like poisonous gases and drugs. Let's start with inflammation of upper respiratory tract and start with tracheitis. It is usually associated with large bronchial inflammation, so often it could be acute tracheal bronchitis. Acute bronchitis. It is the inflammation of the large and medium bronchi. The pathology of small bronchioles is associated with inflammation of the lower respiratory tree. We'll discuss it later. It has the name as pneumonia. But when we see at the bronchi, we see the mucous membrane of the trachea and bronchi is bright red, swollen. Also, we see abundant mucus or pus in the tracheal and bronchial lumen, and we'll see it closely. Look here. Here you see the cross specimen of the trachea and soft tissue next to it. And we see that mucosa on the, you see the trachea is opened, and mucosa of the trachea is reddened and streaked with pus. So here you see such a yellowish cover. This is pus. You must know that patient died from the respiratory infection, and we see here a gross picture of such pathology, tracheal bronchitis. Acute tracheitis associated with the presence of the tracheostomy tube. Here you see the opening. The tracheal mucosa is reddened. Look here, it is hyperemic, so therefore reddened. And there is mucosal ulceration adjacent to the vertical tracheostomy opening. Here it is. So look, this is the opening and the tissues next to it with some tissue defects. The ulceration was caused by irritation from the inflamed valve of the tracheostomy tube. Microscopically, the mucosa is congested and infiltrated by leukocytes. There is a polymorphic nuclear leukocytic or mononuclear infiltrate in the submucosa. There are possible various kinds of inflammatory infiltrates and exudate. We see the catarrhal inflammation sometimes with variants like serous, mucus purulent, or mucopurulent. Their ciliated epithelium is desquamated in some places, and the mucous glands are distended with mucus and show marked catarrhal change. Inflammation may also be fibrinous and fibrinous hemorrhagic. Deep injury of the bronchial wall may result in ulcerous bronchitis. So with the features of ulceration when we see grossly and under microscope. In proximal bronchi, we see the features of endobronchitis and endomesobronchitis. When we look at distal bronchi, we see panbronchitis and panbronchiolitis, which may result in peribronchitis. It means the involvement of tissues next to bronchi. What are possible complications? Acute pneumonia. Commonly we see the features of bronchopneumonia, peribronchial interstitial pneumonia, and chronic bronchitis. Let's discuss pneumonia. What is it, pneumonia? It can be defined as the filling of the air spaces of the lung with inflammatory exudate. The exudate may involve the whole or part of the lobe. When the whole lobe involved, it is termed like lobar pneumonia. If the consolidated alveoli are clustered around the terminal portions of bronchial tree, the inflammation is termed bronchopneumonia. Interstitial pneumonia, it is also termed as atypical pneumonia, is characterized by inflammation in the lungs, stromal tissues, so it means interalveolar septi. We have already seen the picture with microscopic peculiarities of alveoli septi, and we see within the stromal tissues with inflammation in case bronchi. So here you see bronchopneumonia and the foci of the involvement of lung tissue in inflammation, and the whole involvement of the lung lobe. In that case, we call it lobar pneumonia. So bronchopneumonia, when we see the areas of inflammation are usually connected with bronchi, but lobar pneumonia is particularly involving the whole lung lobe. Pneumonia can be a primary inflammation of the lungs, or it can be secondary to another disease process, for example, such as leukemia. The infecting organisms are the same as in case of upper respiratory tract inflammations. Lobar pneumonia, other symptoms, synonyms. It has a synonym, it has another name like Sroupous pneumonia. Lobar pneumonia equal Sroupous pneumonia. It may happen in patients who have poor social and medical care, and are particularly prone to this pattern of pneumonia, which is often caused by pneumococcus, streptococcus pneumonia, or Klebsiella. But please remember, nowadays, we can see the symptoms of lobar pneumonia in case of severe course of COVID-19 infection. Grossly, we see the whole of the lobe becomes consolidated, and therefore it has a name hepatization, because the texture quite remind the liver texture. Here you see also the gross specimen of the lung with the symptoms of lobar pneumonia. This material got from the dissection of the female patient, 38 years old. And we see that one lobe of the lung is consolidated, and its pleural surface is covered with a fibrinous pleurisy. The remainder of the lung is relatively unaffected, but here the arrow shows these tiny fibers of fibrin exudate. So the fibrinous pleurisy is the very important characteristic for the lobar pneumonia. Cut surface of the lobar pneumonia here in this picture. This lung is from another patient, but shows that the consolidation is localized to one lobe. And when we touch it, the texture is very similar to the liver texture. So, for lobar pneumonia, please remember, and that is very important, 4 stages of the disease are recognized. Please remember that the first stage is a congestion, and then followed with red hepatization, so-called red hepatization. Due to exudation, the lung is red and solid. Involvement of the pleura is common and leads to pleurisy. We have already seen such a gross specimen. That is why Sroupous pneumonia, termed also as a lobar pleura pneumonia. This may cause a pleural effusion, which is rich in protein and fibrin and has the characteristic of an exudate. In the third stage, the lung is pale gray and drier, and again it is quite solid and hard texture. So again, similar to the texture of the liver. Therefore, it has a name gray hepatization. In the patient who recovers, the lung returns to its normal state, and we call it resolution. Here you see another gross specimen with lobar pneumonia features. So the entire left lobe is consolidated, and here you see the piece of normal lung and piece of the lobe, the whole lobe with the symptoms of red hepatization. So this is the whole lung and lung lobe with red hepatization. Pathogenesis of the lobar pneumococcal pneumonia. Pneumococci, characteristically in pairs like diplacoti multiply rapidly in the alveolar spaces and produce extensive edema. So here you see the picture, like pneumococcus, after inhalation got the alveolus spaces, and we see here polymorphonuclear leukocytes reaction from the capillaries within the interalveolar spaces, and we see the edema as a result of such action. Here we see in stage of red hepatization, we see a lot of polymorphonuclear leukocytes containing bacteria, and also we see a lot of red blood cells or erythrocytes in exudate, and we see the congested capillaries within the interalveolar spaces, and all these histologically quite common in the stage of so-called red hepatization. Therefore, we see the red coloring of the lung lobe due to large quantity of the red blood cells within the exudate. As the inflammatory process progresses, macrophages replace polymorphonuclear leukocytes and ingest debris, and we have stage gray hepatization, and then the process usually resolves, but complications may be present. So here we see in the picture a lot of macrophages, and also we see fibrin within the exudate. And when after grade hepatization goes the next stage called resolution, but sometimes we have complications. So again, few steps in the dynamics of the lobar pneumonia. First stage is congestion of the alveolar capillaries, and this is followed by exudation of red cells, red hepatization, fibrin and neutrophil polymorphs into the alveoli, and we see the exudate formation within the alveoli. In the stage of gray hepatization, the alveolar capillaries are collapsed and bloodless. The exudate now consisting mainly of neutrophils and polymorphs. And then goes resolution. The alveolar exudate liquefies, and part is coughed up and part is absorbed. And here you see the interalveolar spaces, and here the alveoli filled with exudate. So no air, but exudate within the alveolar spaces. What are possible complications of such pneumonia? They could be divided into two groups, pulmonal and extrapulmonal. So, pulmonal complications connected with lung. The inflammatory reaction usually spreads to the pleural surface, and we see the symptoms of pleurisy. So sometimes it may be a purulent exudate giving an empyema of pleura. The other possible complication, when instead of resolution of pneumonic exudate, this may become organized or replaced by fibrous tissue, And we see a carnified or fibrotic lung formation leading to permanent lung dysfunction. And we have such pattern in case of chronic pneumonia, bronchiectasis, and emphysema. The next possible complication, when the lung parenchyma may break down to form a lung abscess and gangrene, so more severe purulent inflammation. This is commoner with some types of pneumococci and staphylococci. Here, this is a gross specimen of right-sided empyema and left-sided pleural infusions. The cream-colored pus can be seen on the anterior surface of the right lung, and the fluid in the left pleural cavity is blood-tinged. Here you see such fluid, some reddish coloring on this gross specimen. What are possible extrapulmonal complications? There are also several possible complications. For example, infection may spread to give pericarditis, bacterial carditis. The second possible systemic pathology like sepsis in the way of septicemia. It can be a result of pneumonia. Also, such complication we saw sometimes during dissection of patient died from the COVID-19 infection. So they started with COVID-19 infection, then we saw pneumonia symptoms, and the end, septicemia and death from this course of the fatal complication. The involvement of the other organs include otitis media, mastoiditis, meningitis, and brain abscesses. So various complications, extrapulmonal, so look in various locations except. A few words about pathomorphosis. So how pathology of lung has changed nowadays. Modern clinical course of the lobar pneumonia is commonly so-called abortive. So it means that some stages, classical stages, missed. So no such staging as we just discussed. Why it happens? This is a result of intensive therapy with modern antimicrobial drugs. Severe complications are unusual findings. Nowadays, it rarely results in death of the patient, but as I said before, some severe cause of infection like COVID-19 unfortunately cause fatal outcome. What are causes of death? In most cases, heart and lung insufficiency. So fatal outcome is registered in 3% of lobar pneumonia. Now we go to another kind of the inflammation in respiratory system, bronchopneumonia. Initial infection in bronchi may have an extension into adjacent alveoli. This results in inflammation of lungs parenchyma, which have a patchy distribution within the organ. Grossly, the involved lungs appeared congested, edematous, and on palpation may feel lumpy, airless, and firm. When the cut surface is examined, the diagnostic feature is a cluster of solid nodules which have dark red or gray appearance surrounding small bronchi or bronchioles, which is seen under microscope. Initially, consolidation is patchy within the lung, involves lobules sometimes, but if untreated, it could involve lobes and become confluent. So here we see the gross specimen of the lung with the areas of bronchopneumonia. So here the arrows shows the pictures of the consolidations of lung parenchyma. Here it is greenish brownish area which have the boundary from the other normal zones of the lung parenchyma. Here we see the sample of the lung with confluent bronchopneumonia. As distinct from the lobar pneumonia, bronchopneumonia is focal and involves many areas of the lung. The focal collections of pars may become confluent, giving rise to abscesses, as demonstrated here in this picture. There is no pleural reaction associated with this type of pneumonia, and the lung itself is emphysematous. So here we see another picture, the sample of the lung tissue with bronchopneumonia. We see scattered foci of the consolidation, which are seen here, various areas. Darker places are normal lung, and reddish, yellowish areas are the foci of consolidation due to bronchopneumonia. Histologically, primary infection centered on bronchi spreads to involve adjacent alveoli. The bronchiolar wall is inflamed and its lumen filled with polymorphs. The adjacent alveoli show similar changes, please remember. The more peripheral alveoli are congested and edematous. The inflammatory reaction here being at an earlier stage of evolution. With severe infections, adjacent solid areas coalesce to produce an incomplete lobar pattern. As I said before, it may happen, for example, in case of the pneumonia, COVID-19 pneumonia. In severe cases, we see the features of lobar pattern. Bronchopneumonia, most common in infancy and old age, is predisposed by the presence of immobility of the patient. Patients who are immobile develop retention of secretions. These gravitate to the dependent parts of the lungs and become infected. Hence, bronchopneumonia most commonly involves the lower lobes, and we call such kind of pneumonia like hypostatic pneumonia. So it happens often in patients with immobility after various surgeries, etc. Bronchopneumonia is more serious than lobar pneumonia sometimes, for it always causes some destruction of the lung parenchyma. In old people already suffering from the chronic lung disease, this additional destruction further reduces the pulmonary reserve. Let's discuss few variants of bronchopneumonia. For example, suppurative bronchopneumonia. We see some on the cross-section of such pneumonia, we see multiple abscesses within the consolidated areas, and it is common picture in case of staphylococcal infection. This disease of considerable gravity patient. The mycoplasma causes pneumonia, histologically presented with the exudate in the alveolar wall, which consists predominantly of histiocytes and lymphocytes rather than polyps. The other kind of pneumonia caused by streptococci. This is the most common cause of community-acquired pneumonia. It may be related to viral infection, for example. The pathology of the lower lung slopes is a constant find in this case. Streptococcal pneumonia may result in multiple acute abscesses and bronchiectasis. Few words about hospital-acquired pneumonias. They are caused by gram-negative bacteria like Klebsiella, Escherichia coli, Pseudomonas, Proteus, Serratia. They occur about 72 hours after admission of the patient to the hospital. Immune insufficiency, old age of the patients predisposed to such hospital-acquired pneumonias. Pleuritis and abscesses are the common complication of hospital-acquired pneumonia. Aspiration pneumonia is caused by regurgitation during episodes of unconsciousness or in patients after stroke, for example. Chemical damage by gastric acid results in pneumonitis, increasing respiratory dysfunction, and mixed infection, superimposed infection like various bacteria, Staphylococcus aureus, and others. What are possible complications of bronchopneumonia? Of all of them, for all various patients with bronchopneumonia. At the end, in the end stage of such disease, carnified or fibrotic lung may happen. Also, the bronchopneumonia could result in lung abscesses formation. Pleurisy may cause a pleural effusion, which gives an empyema of pleura. Here you see the gross specimen with empyema and lung abscesses. This was a complication of staphylococcal pneumonia. Abscesses are present in the upper lobe. We see the arrow here. This is abscess. There is a large amount of pus covering the surface of the lower lobe. Here we see the arrows showing the cover of the lower lobe of the right lung. The visceral pleura is thickened and posteriorly some thickened parietal pleura is adherent to it. So you see some adhesions. Now we go to interstitial pneumonia, so-called atypical pneumonia. The chronic inflammatory cell infiltrates alveolar space septa, developing the acute pneumonitis pattern. So please remember, when we see the inflammatory infiltrates within the septa between alveolar spaces, we call it pneumonitis. When we have the exudate within alveoli, we call it pneumonia. So this pneumonitis or interstitial pneumonia, it means the, as I said before, infiltrates within the interstitium of the interalveolar septum. The chronic inflammatory cells infiltrates alveolar septi, developing the acute pneumonitis pattern. Please remember, this may be caused by some viruses, chlamydia and rickettsia. Also, for example, COVID-19 also could have a pattern of interstitial pneumonia. It also happens as a result of chemical poisoning, radiation, uremia, rheumatism, and, for example, in case of leukemia. We also discussed this issue before. In this picture, we see the pathogenesis of interstitial pneumonitis. Although interstitial pneumonia is most commonly caused by viruses, other organisms may also cause significant interstitial inflammation. So you see the list of various infectious agents like viruses, rickettsia, chlamydia, mycoplasma. Then, in case of inhalation of such agents, we see the reaction of the type 1 pneumocytes, the capillaries congestion, so the entry to interalveoli, then type 1 cell, which are quite sensitive to damage, lose their integrity, and at the end of such process we see intra-alveoli edema. Then the proteinases exudate and cell debris form hyaline membranes, and type 2 cells multiply to line the alveoli. In this case, here you see the hyaline membrane. We see hyperplasia of type 2 pneumocytes. We see interstitial edema, interstitium of the interalveolar space, here it is, and we see predominantly mononuclear exudate. So mononuclear cells are dominate within these exudate. We see possible two ways of outcome. It could lead to resolution or interstitial fibrosis. The same morphology and the same outcomes could be possible due to COVID-19 pneumonia. So we see the result that the disease resolves completely sometimes in the majority of cases, or in some cases, severe cases, we see they result in interstitial fibrosis. So lungs are firm, slimy and meaty, so looks like meat texture. Under microscope, alveolar septa are thickened, infiltrated with mononuclear cells and admixture of neutrophils. Measles, for example, may cause an interstitial pneumonitis characterized by formation of multinucleate giant cells, diffuse necrosis of alveolar epithelium in severe cases, followed by hyaline membrane formation and edema in alveolar, is also important histological pattern of the disease. Late stage of the disease is characterized by interstitial proliferation and honeycombing. So we see the lung, a so-called honeycomb. Therefore, in this case, patient may die of the lung and heart insufficiency. You see, if honeycomb is accompanied, as usually happens with alveolar capillaris block, we see the hypertrophy of the right part of the heart, right ventricle of the heart, and then with time the outcome could be the insufficiency of the heart. The other kind of pneumonia is pneumocystic pneumonia. Pneumocystis carinii is a cause of the disease which is the most common in AIDS. Please remember, this kind of pneumonia, pneumocystic pneumonia, often diagnosed in AIDS patients or immunosuppressed patients, for example. Immunosuppression may be a result of immunodeficiency syndrome, primary immunodeficiency syndromes in children, debilitated adults, and, for example, in case of such disease like leukemia with immunosuppression or with various transplantation surgeries and immunosuppression due to usage of various drugs, and all this may be complicated by pneumocystic pneumonia. Microscopically, we see foamy material with few inflammatory cells. Within the alveolar exudate, alveolar septa are infiltrated by lymphatic cells, histiocytes. We see also under microscope hyperemic vessels, and all these is a common sign of the inflammatory reaction in this kind of pneumonia. Look here, we see histological slide from a tissue sample of the lung of patient with pneumocystic pneumonia. So look here, we can't see even the air within this lung tissue. So the lung is airless, no air, because the airspace is filled with exudate. And this exudate is quite specific pattern, like foamy exudate. And the interstitium of the septa next to the alveoli, we see that interstitium is thickened and contains a lot of chronic inflammatory cell infiltrates. So that is quite characteristic for cystic pneumonia. Here we see the centrifuged bronchoalveolar lavage specimen impregnated with silver, which shows a cluster of pneumocysts. So this investigation may help to make diagnose. Very interesting point is the question of pathomorphosis of pneumonia. So what is it, pathomorphosis, from our point of view? It means modern changes of the clinical and morphological peculiarities of pneumonia. You must remember that the commonest picture of pneumonia seen at the present time consists of the non-specific combination of congestion and edema. This is because of antibiotic therapy, which is practically invariably given to patients. As I said before, various inflammatory complications in lung and extrapulmonary complications, and of course fibrotic lung and honeycomb lung formation, and as a result of it we may see the death of a patient from the not only lung but the heart insufficiency. The second big group of diseases, chronic non-specific pulmonary diseases, which have different etiology, pathogenesis, morphology, but grouped together as all of them produce similar clinical syndromes and abnormalities and ventilation. And all big group of such disease we'll discuss at the second part of this topic of lung disease in more details.